Hello everyone, welcome back to my channel. Today I will be talking about the management of hypermature cataract with the fibrosis of the anterior capsule. So let's start with the case. As a routine surgical steps, side ports are made and the anterior capsule is stained with the help of trypan blue dye and it is left for around 10 seconds. In these type of cases, the zonules are weak and compromised. So the dye can percolate through the zonules and may enter into the posterior cavity. After staining, anterior chamber is filled with the HPMC and now the capsular axis is initiated. After staining of the anterior capsule, I can see a dense central plaque at the anterior capsule which is extending up to the periphery. As I try to puncture the anterior capsule, I came to know that it is very leathery and thickened and I could not get a proper flap to initiate the curvilinear capsular axis. Here, I don't want to get too aggressive because of the movement of the capsular bag with the multiple attempts. So I gave a nick at the known fibrosed area of the anterior capsule and I am able to make a triangular flap. But due to extensive fibrosis of the anterior capsule, I had to give few nicks from the opposite side, similar to can opener techniques. From this point, I am able to get a continuous axis, which is again stuck at the peripheral fibrosed area. So I had to start it again from the opposite side in a can opener manner. Here I am applying small and slow strokes with a centripetal force, and here I am able to get a decent size of axis. And here we got a thick disc of anterior capsule. Now the main port is made with the help of 2.8 millimeter keratome. Now very gentle, extremely gentle hydrodissection is performed. Obviously you cannot do hydrodelineation. So simultaneously I am performing a sweeping movement with the help of hydrocannula itself. And now visco is put into the anterior chamber and emulsification is started. Here the nucleus appears to be free floating, but it is large enough. I will be performing direct chop. So the tip is completely buried into the central core of the nucleus, and here we go with the first crack. With the first crack, I came to realize that it is quite thick and I am not able to get a full thickness crack in which posterior fiber seems to be quite attached. So I decided to rotate the nucleus and attempt crack from the other side. And while doing so, nucleus seems to be coming out of the bag. And for this particular case, this is a good thing because the axis margin is discontinuous at certain places. With the nucleus out of the bag, I have avoided two complications. First is the capsular axis extension toward the equator, and second is the stress at the zonules. So the stress at the zonules is avoided because this patient has already generalized zonulopathy, which was already seen during capsular axis. So what I have done here is that I have made multiple pieces, and each piece is taken out of the capsular bag and then emulsified and aspirated. So throughout the process of emulsification and aspiration, A constant subconscious thought is there in my mind, which is compromised on your back. With the consumption of OVD, it is again refilled into the anterior chamber. Now, the remaining last piece is chopped and emulsified. Now, the HPMC is put and irrigation and aspiration is done, and I prefer to use bimanual mode of irrigation and aspiration. Now the hands are switched and the cortex from the other side is also aspirated. And finally, the implantation of IOL is done. And it is gently dialed into the capsular bag. So this is it for today. Thank you so much for watching the video.